Dear everyone, I would like to welcome you in the next session of OnDemand On Demand series. It's a great honor to me to be here and present a lecture for you. First of all, let me introduce myself in a few words. My name is Kinga Körmöczi and I'm working as an assistant professor at the Department of Oromaxillofacial Surgery of the Semmelweis University in Budapest, Hungary. Today in my lecture, I would like to talk to you about the new approaches of bone regeneration with using autogenous materials. The content of my lecture is first of all a little overview about the bone regeneration and the bone augmentation. After the overview and the features of the autologous materials, and at the end I would like to show a few cases of mine. The first question is, what are the indications or when it is necessary to make a bone augmentation in the mouth of the patient? It is true that after when the patient loses a tooth, we have to face some type of tissue loss. It is true for the soft tissues and it is true for the hard tissues for the bone that the patient will lose after tooth extraction. So that's the reason why when we plan an implant treatment for the patient, that before or together with the implant rehabilitation, we have to make bone augmentation as well. Let's see a little bit the process of the bone regeneration. As you could see on that slide, that it has 4 phases. The first, the hemostatic and coagulation phase, after inflammatory phase, proliferative phase, and at the end, the modeling and remodeling phase. The bone demonstrates a unique potential for the regeneration. So it has the feature to heal fractures, to heal little bone defects with regenerated tissues of equally high structural organization, without leaving any scar tissues right there. So at the end of the healing process, with the modeling, it indicates the change in shape, whereas the remodeling refers to tissue replacement or substitution without a change in architecture. So if we look through on this complicated process, we could see that there are several types of cells which could play roles, for example, osteoblasts and osteoclasts, and these processes are modified by the growth factors. The osteoblasts could be found on the periosteal and endosteal surfaces where the bone formation is active, and they are responsible for the synthesis, the assembly, and the mineralization of the bone. The osteoclasts, as you could see right here, they are much more larger than the osteoblasts, and they are multinucleated cells, and the primary function of them it is to degrade the bone matrix. So what is happening after when we remove a tooth from the alveolar socket? You could see that there are 2 ways. So if we let this area heal by itself, there will be, because of the modeling, there will be a volume changing in the vertical and in the horizontal dimension. So at the end of the healing process, there will be a new bone formation, and it is the bone such like same that it was previously, but the amount of the bone, it is not the same. When we replace that area where the tooth was with some bone substitutes or with some materials, there will not be any change, or the change will be very, very small in the dimensions. That gives the base of the GBR technique, which means the guided bone regeneration. So when we make a guide for the regeneration of the bone, we will not lose the amount. When the tooth is already removed, we have the opportunity to replace the bone, to rebuild the bone, and get the same volume as it was previously. So what is the importance of the GBR technique? So first of all, somehow we have to make the exclusion of the gingival tissues, because the regeneration of the gingival tissues are much more quicker than the regeneration of the bone cells. On the other hand, it is very important to maintain a bacteria-free area during the healing period. So that's why, as you could see on that slide, so when we are making guided bone regeneration, we have to use some type of materials which will exclude the gingival tissues and which will keep the bacteria-free area. And usually we are using some type of membranes for solving this problem. But what else it is necessary for make new bone formation and for make guided bone regeneration for the patient? So as I mentioned to you, first of all, the scaffold, the space for the regeneration, it is essential. This space could be maintained by some bone substitution material. And also it is very important that that area has to have a support from the own bone of the patient. So when we have a defect, at least one or two walls of this defect has to be the own bone of the patient to support the area and to get the cells and growth factors right there and to reach the normal bone regeneration. So that's why not only the scaffold is important for the regeneration, but the cells which are making the regeneration and which are making the new bone formation. Also, it is necessary to have the growth factors which will mediate this whole process. And also we need time for the healing period. It is also very important to have a peaceful, healthy biologic environment around our augmented area for the undistributed healing. There are three types of mechanisms in the bone regeneration: osteogenesis, osteoinduction, and osteoconduction. When we are talking about the osteoconduction, we have only the scaffold in the regenerated area. So first, the system of the body has to take there the cells first. After there are the growth factors, and it starts to be a vessel formation there, so the angiogenesis, and after it start to heal, start the whole process of the regeneration. But today I would like to talk in details only about the osteoinduction and osteogenesis. So when we are talking about the osteoinduction, we have the scaffold and we have somehow the growth factors right there. So that's how we called it. It is a stimulation of the bone regeneration mediated by the growth factors. When we have everything in the same time and in the same place, scaffold, cells, growth factors, we are talking about osteogenesis. So we are providing all biologic factors of the bone regeneration. What kind of substitutes could we use for regenerating of the bone? We could use autografts, which will be playing main role in my lecture, allografts, xenografts, and alloplastic materials. As I mentioned to you, we have to exclude the gingival tissues, and we have to maintain this scaffold, this space for the regeneration. So that's why it is necessary always to use a non-resorbable or a resorbable membrane to making the guided bone regeneration. It depends on the surgery technique, and also it depends on the defect side, that how big volume should be replaced, that what type of membrane will we choose. But it is important in both of the membranes to fix them with screws or maybe pins, because the movement will not let us to provide undistributed healing for our augmented area. So the fixation of the membranes, it is essential and it is very, very important. What kind of surgical procedures could we make, like bone augmentation? We could make alveolar socket preservation, where the purpose of this surgical method is to maintain the vertical and lateral dimension of the alveolar ridge until the end of the healing process after the tooth extraction. It is the easiest way, I think so, to make bone augmentation. The next is the sinus lifting, which is the vertical augmentation of the maxillary base, and we could make horizontal and vertical ridge augmentation. Right here you could see that I collected some publications according to the success rate of this type of procedures, and we could find that the highest success rate it is in case of the sinus lifting, but also in case of the socket preservation we could find a quite high success rate. It is because if you imagine that when we remove a tooth or when we are making sinus lifting, the support from the own bone of the patient it is coming from 5 or maybe from 4 walls. So it means that the support, it is very big in these cases. So that's why it will enhance the bone regeneration procedure. And also in case of the sinus lift, because we are working in a closed cavity, which is the maxillary sinus, and we closed the wound on the top of it, and we are augmented not under our flap but inside the maxillary sinus. That's why the healing, it's totally undistributed, and that's why the success rate is quite high. In case of the horizontal and the vertical ridge augmentation, the support from the own bone, it is less, because we are going to have 3 or 2, or in case of the vertical augmentation, only 1 wall defect. So it means that the support is only from 1 wall. So that's why the healing period takes much more longer, and that's why the success rate is a little bit lower, even if it is quite high. Also, we have to say that the complications after bone grafting mainly occurs in case of vertical and in case of horizontal ridge augmentation. As you could see on that slide, we have several types of complications, but there was a consensus conference by the European Workshop on Periodontology on Bone Regeneration, and they made statements that the most common complications are the wound dehiscence, the membrane exposure, and the graft exposure and the graft loss because of these complications. Less common complications was the infections and the graft loss because of the infections, the paresthesia, and the major swelling. There was an examination where they stated that the average rate of the complications was not so high, it is around 17%. And also they stated that the complication rate was highest in case of making the types of surgery of destruction osteogenesis. It was the less in case of guided bone regeneration, and it was a little bit higher when we are using bone blocks for bone replacement. The insufficient flap healing, the flap dehiscence, could occur after in every types of bone augmentation. So you could see on that picture it was after sinus lifting, right here it was after horizontal ridge augmentation, and right here it was after vertical augmentation. Mainly the cause of this flap dehiscence, it is that we are increasing the volume of the bone under our flap. And even if we are making, after the surgery, before we close a flap, we are making the enlargery of the flap, but it is very hard to close it tension free. And if there is a little tension in that area on the top of our augmented area where we replace together the edges of the flap, there will be a flap dehiscence or a flap opening, which could cause complications. The flap dehiscence could be classified in several ways. One is the time that when we face with the flap dehiscence or flap opening, and the other is that how big the area is where the flap is open and if we have inflammatory signs or not. In the first class, we take the dehiscences when it is in small area, so the opened area is less than 5 millimeters without any inflammatory signs. It could happen after when we used bone blocks as augmentation materials, or it could happen when we are using some type of particulated bone substitutes, autografts, allografts, xenografts, and so on. The treatment, it's not the same, so it depends on that what kind of materials did we use during the surgery, and also it depends on that if we lose the membrane when we could see the dehiscence or not. When we used bone blocks and we lost the membrane on the top of the block and the flap is open, there is a dehiscence and we could see our bone block, but there is no inflammatory sign and the area is quite small, we could drill a little bit the sharp edges of the bone and we could wait for the perisecundum healing of our flap on top of the block. But it is necessary to use local antiseptic, and it is very important the close recall follow-up of the patient, so we have to check it in every third day that if it is started an inflamed process or not. In case when we used particulated graft and we have the membrane on the top of it, so we could see the membrane under the opened flap and there is no inflammatory sign. Also, we have to make a very close follow-up. We have to use local antiseptics. We could use soft laser therapy, and we have to wait and keep the area in the same situation at least for 2 months. After 2 months, it is possible to remove the membrane and after close somehow the flap on the top of it, because until the first 2 months, the regeneration of the bone, it's on that stages that we have to make after only for the mineralization of the area. In the class 2, we placed the distances where the area is bigger, so the opened area is more than 5 millimeters, but no inflammatory signs. The treatment, it is the same that it was in the first class, but we have to expect that after the healing period, maybe soft tissue augmentation will be necessary. In class 3, there is no wound opening, there is no dehiscence, but there are inflammatory signs of the augmented area. It is a rare incidence, fortunately, but in that cases we have to give a high dosage of antibiotics, local antiseptics, and when it is necessary we have to make an incision and we have to make the drainage of the area. In class 4, it is wound opening on small area but with inflammatory signs. It is also fortunately a rare incidence, but when it is happened, we have to consider that if we are removing our augmented area and weight or not, so it's not an easy complication to be solved. In class 5, we have wound opening in a big area with inflammatory signs. It is also fortunately a rare complication, but in that case there is no question we have to remove all the materials that we placed in and we have to wait for the healing period, and after that we have to consider the risk and the benefits for the patient, that if it is good to make a new bone augmentation procedure, or we have to choose another type of treatment plan for the patient. Many of these complications are happening in case of the vertical augmentation, because in case of the vertical augmentation we will increase mostly the amount of the new bone tissues, so that's why the flap dehiscency and membrane exposure causes many of the cases in the vertical augmentation. How could we avoid from these complications the patient and us as well? I think that it is very important the inappropriate choice of the surgical technique and the inappropriate choice of the materials. So if we have a defect, we have to measure that how big the defect is, and how big amount of materials we want to place on that area, and what kind of materials do we choose. You could see on that table that according to Mish, that in most of the cases, or maybe in all of the cases, they recommend to use some autogenous materials, because with the autogenous materials we could turn the bone replacement to the mechanism of the autogenesis, because in the autologous bone there are the cells, the growth factors as well, and it is also a scaffold, and it will enhance the bone regeneration, it will make it a little bit quicker, and that's why we could get a better result. But not only the own autogenous bone usage is recommended, but all types of autologous materials. What kind of materials could we have? First, as I mentioned to you, the autogenous bone, but we could make or reach autogenous blood products and also autogenous dentin particulate graft. The autogenous bone could be harvested extraorally and intraorally oral sites as well. As a dental surgeon, we are able to harvest only intraoral sides the bones. Extraorally, it is made by the maxillofacial surgeon because it is always made under intratracheal narcosis, and we could reach quite a big amount of bone after when we are removing extraorally. So it is not necessary to every cases to harvest a big amount of the own bone from the patient. What are the intraoral bone harvesting sites? So they are the tuber maxillae, the mantle. The rate of the incidence in case of vertical bone augmentation, it is quite high, because in case of vertical augmentation, we will increase the amount of the new bone for the most. So that's why it is very, very hard to close the flap on the top of the vertical augmentation tangent-free. So that's why many of the cases occurs flap dehiscence or flap opening, and that's how maybe some inflammation and the loss of the graft. How could we avoid from the complications the patients and ourselves as well? I think that it is very important the appropriate choice of the surgical technique and the appropriate choice of the materials that we use during the surgery. As you could see on that table, according to Mish and the co-workers, so it is worth to measure the dimension of the defect that we want to replace or rebuild as a new bone, and that's how we could choose our materials. But as you could see that in every of the cases they recommend to use some types of autogenous materials because they are the gold standard and they have the cells and they have the growth factors inside. So that's how we could provide an osteogenesis which will enhance the healing period and the result. So it is very important that what kind of bone substitutes will be used, what kind of membranes will be used, the resorption time of the membranes, and also it is very important to fix the membranes correctly with pins or with screws. So the technique it is also very important. What kind of autogenous materials could we use? So first of all, we could use the autogenous bone, we could use autogenous blood products, and we could use the autogenous dentin particulate grafts. The most common is the autogenous bone. We could harvest the bone extraoral and intraoral sites. Extraorally, we harvest it only together with maxillofacial surgeons, and these type of surgeries are made under intratracheal narcosis, and from extraorally we could reach a quite big amount of own bone from the patient. So we are using the type of surgery only when the defects are very big. Many of the cases we use the intraoral bone harvesting, and the most common sites could be seen here on that slide. So the tuber maxillae, the mantle, the retromolar area, the anterior nasal spine, and the edentulous alveolar ridge from itself. The intraorally harvested bone could be reached with some type of scrapers as a particulate bone graft, with some type of drills, for example the curved trephine, the round trephine, where we could reach bone cylinders. We could reach corticospongiosus blocks with using piezoelectronic devices, and also we could use some type of special drills to collect the bone and place it back in the area where we want to make the bone augmentation. The next autogenous materials are from the blood products are the plated concentrates. About 20 years ago, it was written down that the plates and the growth factors has a quite big role in the wound healing process. So that's why the aim was to make a device which could separate from the blood the plate and also the growth factors for using it to the bone regeneration. The advantages of these plates concentrates that they are autogenous materials, so it means that they are gold standard. They will speed up the revascularization of the tissues of our augmented area, and also they will speeding the proliferation, and they will recruiting variosus cells, including the stem cells as well. There is only one disadvantage of this type of product. It is the short resorption time. So they will resorb in 2 to 3 weeks. So that's why many of the cases we will mix this type of products with other types of bone substitution materials, or maybe we will use it with some type of other membranes, so we are not using this type of products in itself. If we see the stages of the wound healing, we could say that there are 3 stages: inflammatory, proliferative, and regenerative phase. And the plates and the growth factors and fibroblasts has a quite big role in these stages, such like it was previously on my first slide in case of the bone regeneration. The contents of the blood, it is mainly the plasma of the blood. We have red blood cells, white blood cells, plates, and also growth factors inside. On that picture, you could see the difference between the plates, white blood cells, and red blood cells, and it is visible that they are different in the sizes and also in the weight of it. So that's why during centrifugation, it is quite easy to particulate them, and we will reach that types of cells in different layers. The first product was made is the PRP, so the plated rich plasma, which has a quite high accumulation of the plates and of the growth factors, but it had a disadvantage, the long production time, and they added anticoagulants for making this product because of the longer centrifugation time. So that's why it is working very correctly, and it is enhance the healing process. But they wanted to eliminate the anticoagulants from this type of products. So that's why they developed the devices for the PRF, which is the plated rich fibrin. It has less centrifugation time, and it is not necessary to use anticoagulants to make or get this product. It has 3 layers. On the top, we could find the acellular plasma layer. After that, the fibrin clot, which is white. And on the down part, it is the red corpuscle base, where we could find the red blood cells. The consistent of this product, it is gel. So that's how it is not only just concentrates of the cells, but it could be also a scaffold for the wound healing and for the new bone formation. We could find the leukocytes in the white particle in the middle part of this product, and also they have the larger growth factor release profile. There are several types of forms in the PRFs. So the main components of the PRF are the bioactive molecules, so the growth factors, which are essentials for the wound healing and for the bone healing. They have a scaffold because the consistency is gel formate, and also they have the cells, the plates, and the leukocytes, which are also very important in the soft tissue and in the hard tissue regeneration. There is 2 types of production, and there is 2 devices. The first is the fixed angled device, and the next is the horizontal centrifugation technique. It is almost the same. There is one difference, as you could see right here, that the border between the red and the white corpuscle base, it is a little bit sharper in case of the horizontal technique, but both it is working very well. What are the protocols for producing PRF? We could make with the horizontal technique L and A PRF and also I PRF. A and L, it is a gel consistent PRF. Mainly we are producing the A PRF because, as you could see, that it has the better distribution of the leukocytes in the white particle, and also the production time, it is less. The IPRF, it is the injectable PRF, which is liquid. it could be used for producing a special type of PRF. I will explain you a little bit later. And with the horizontal technique, we could reach the H and the CPRF as well. The CPRF has the highest accumulation of the plate and the leukocytes inside. The forms could be the PRF plugs, which are very easy to get, because when we are removing the PRF from your tube and we cut the red corpuscle base with the scissors, we will get the plugs. From the plugs, we could press membranes. We could reach the sticky bone from the PRF. For the sticky bone, we have to make a PRF and injectable PRF as well. We could harvest autogenous bone, or we could use the some type of other bone substitution material, allografts, xenograft, and alloplastic materials. So we mix together the APRF, the bone substitution material, and the injectable PRF together. And in few minutes, you could see that we will get a gummy consistent thing, which is in one part, and it is quite hard. So it is act like bone block, and we could use it in one piece, or we could cut it with copper, or we could cut it in several little pieces with our scissors. As I mentioned to you previously, that the resorption time of these products are quite short, and also the resorption time of the membranes is quite short. So the normal PRF membrane couldn't be used for GBR technique in itself. But they wanted to make the production time a little bit longer, so that's why they developed the ePRF membrane, which is a little bit complicated to produce it, because we need not only the centrifugation device but other devices as well. If you are interested in it, that's why I copied the QR code inside, because you could find a video about the ePRF, the production, and also the features. But the main advantage of this membrane that it takes 4 to 6 months for the resorption time. How could we apply the PRF in implantology? First, we could apply it in case of the socket preservation. So when we remove a tooth, we could place PRF plugs in itself inside the alveolar socket. It is the success rate of this type of socket preservation, it's quite high, but the literature wrote down that we could get the best result if we mix the PRF plugs or the IPRF with some other types of bone substitution material. We could use it also in case of the sinus lifting, but the PRF in itself used for sinus lifting recommended only in cases of narrow sinus, when we want to make a little elevation between 3 to 4 millimeters. In other cases, it is recommended to mix the PRF with other bone substitution materials. But the PRF membrane could be used for one complications in case of sinus lifting, and it is the rupture or the perforation of the Schneiderian membrane. When the perforation is less than 5 millimeters, the PRF membrane could be used only in itself for the coverage. But when the perforation is more than 5 millimeters, we have to use in the first layer the PRF membrane, and on the top of it we have to place a collagen membrane, and after we could continue our surgery. The clinical studies found a very good success rate when the bone substitution material it is mixed with some type of PRF during sinus lifting. In case of horizontal and vertical bone augmentation, also as I mentioned, the PRF in itself it is not recommended to use because of the short resorption time. But in case of the GBR technique, when we mix it with other types of bone substitution material, it will enhance the success rate, it will make the healing process a little bit quicker, and we could get a very good result. Mostly we are using the sticky bone form because it's very easy to work with, and when we are mixing the sticky bone, so we could be sure that all of the cells are inside also in our grafted material, not on the surface part. It will enhance the revascularization, so that's how it could enhance the whole process. Also, it is very important that when we are ready with the augmentation area and before we close the wound on the top of it, it is recommended to use a PRF membrane because it could enhance the regeneration of the soft tissues, and maybe the closure of the soft tissues will be a little bit quicker, so we could decrease the rate of the flap dehiscence and the membrane exposure. The last autogenous material that I want to talk about, it is the dentin particulate graft, which is a quite new and innovative method for ridge preservation and for bone augmentation. During this process, the extracted tooth, it is grinded by a special device. Before the grinding, we have to clean the roots and the crown of the tooth. For this material, we could use wisdom teeth as well, which are, when they are impacted, they are totally healthy with the living pulp. But we could use teeth which are restored and which has fillings, root canal fillings, and so on inside. But before the procedure, we have to clean off all the surfaces, we have to remove the restoration, we have to remove the fillings, root canal filling, and if there is any cavity, we have to remove the inflamed areas. After this preparation, we have to place it into a device, and in the device, with the multi-phase cleaning, we will get a particulated graft from the tooth. It is very important that this type of products has osteoconductive and osteoinductive features, so it means that it is a very good scaffold, because at the end the consistence is just like the same that, for example, an allograft or a xenograft or an alloplastic material. There are different types of devices that you could reach, and they are different only in the size of the particles and the end, and some devices are totally automatically, some devices need some freehand preparation, and the numbers of the faces are not the same. The features of this type of grafts, it is that they have an ideal physical and chemical properties, and they has to be found to stimulate the bone formation. The human dentin, it's composed of 70% inorganic content, 20% organic content, and 10% water. Because of the 70% inorganic content, which is 4 types of calcium phosphate, they are a very good scaffold, so they have the osteoconductive properties. Because of the growth factors inside, they have the osteoinductive properties as well. So that's how they are acting very good, such like bone substitution material. At the end of my lecture, let me show you some case of mine where I use this type of materials. The first patient, it is a middle-aged female patient, and she came to me in the state like this. So she had a chronic periodontitis on the upper jaw, and all of the tooth was hopeless, and they removed it. The patient came to me after 4 months after the tooth extraction, and at the first sight the amount of the bone looks quite good, but after, when I made a CT scan, I could see that the patient wanted a fixed implant supported restoration, so not removable. And as you could see that in the key position, the healing was not good. So there are big bone defects in everywhere, in the vertical dimension and in the horizontal dimension. So I decided to make a big lateral and vertical bone augmentation first the patient, and after we will place the implants in. When I made a quite big flap, you could see the insufficient healing, and you could see that there are a lot of defects everywhere in the jaw. So I chose to use xenograft, mixing with PRF plugs and mixing with the IPRF. And I choose the collagen membrane as a coverage. Collagen membrane was fixed by pins on the palatal and also in the buccal side, as you could see right here. And at the end, when I made the bone augmentation, I prepared also PRF membranes, and I covered my collagen membrane with the PRF membrane. And here you could see the closure after the surgery, and it was only 1 week after the surgery when the patient came back for the suture removal. So we could see that the healing of the soft tissues are excellent. So the PRF membrane, it's helped us for the quiet, quick wound healing. And now the patient is waiting for the healing for the hard tissues and for the implant placement. The next case, it is also a middle-aged woman. She had a bridge on the lower jaw on the right side, and this bridge was broken 2 or 3 times. And the patient came to me that please replace the teeth with implants because the bridge is always broke. When I throw in the mouth of the patient, what else I see immediately, that she had a quite big exostosis in both sides, on the lingual side of the mandible. So we made a CT scan, and as you could see that even if the horizontal dimension of the alveolar ridge, it is very good and quite big, so it is good for implant placement, but the angulation, it's not good. So there was an atrophy on the horizontal dimension. That's how, as you could see, that the prothetician has to place the bridge on the lateral wall of the alveolar ridge, so that's why the masticatory forces was not good, and that's why the bridge broke in several times. So if I want to reach a good loading of the implant, where the distribution of the forces are good, I have to make a vertical augmentation to buccally to place the implant into the correct position. So that's why even if the ridge of the width of the alveolar ridge, it is quite good, we had to make a horizontal ridge augmentation for the better angulation and for the better loading. As you could see on the CT scan, that the exostosis, it is quite big and it is very close to my area where I want to make the bone augmentation. So I choose the technique where I remove this exostosis with a piezoelectronic device like a bone block. So first I cut it down. As you could see that I had to make a quite big envelope flap until the midline of the patient, just not to make a rupture of the flap. After, when I removed this block, I also harvested some particulated bone graft from the patient, and also we prepared PRF plugs and membrane. So first I fixed the block on the buccal side of the patient, and after I filled the gaps and the other areas with this particulated own bone mixed with the PRF. After I covered it with the collagen membrane, it was fixed by pins on the lingual and on the buccal side, and on the top of it I covered it with the PRF membrane. Here you could see the closure of the wound immediately after the surgery, and 1 week after. Also the healing of the wound, it is excellent, and there was no flap dehiscence. We waited for half a year for the regeneration of the bone. We made another CT scan, and right now you could see that the alveolar ridge, it is very wide, but I am able to place the implant into the correct angle to reach a very good load of it. So here are the pictures of the second surgery. So first I made only a little flap. Also in the envelope flap, I removed the screw from the block and I placed the 2 implants in. And right now the patient is waiting for the crowns. The third case, it is also a middle-aged woman, and she had a bridge in the upper jaw on the left side, and there was a vertical fracture in the canine. There was a symptoms of the patient, but the patient waited for 2 years with these symptoms, because sometimes she felt pain, sometimes not. But during these 2 years, the inflammation was so big and there was a big fistule on the buccal side and pus formation and so on that I was not able to make an alveolar socket preservation in the same time when I removed the canine. So I decided first to remove the canine, wait with this big inflammation to heal, and after make a horizontal ridge augmentation of the patient. Fortunately, this patient also has an exostosis, but in the molar area on the buccal side. So I also decided to use this exostosis to make the bone augmentation. On the control CT scan, you could see that there is a quite big defect in the horizontal dimension. So I had only a 2-wall bone defect that I have to replace. But also it is visible that the exostosis is quite big, so I could reach a quite big amount of particulated on bone. Here you could see the size of the exostosis. Right here I decided to remove it with a scraper, not with a piezoelectronic device, because the vertical dimension of this exostosis was quite small, so I thought that it is not able to fix it with a screw, so that's why I used it as a particulated graft. We also prepared a plug and a membrane PRF, and I also prepared the injectable PRF, and I mixed this particulated bone with IPRF and with the PRF plugs, because I had to make a little vertical augmentation as well, not only horizontal one, and in the horizontal dimension it was a quite big defect, so that's why I decided to use a non-resorbable membrane in this surgery. So you could see the membrane also fixed on the buccal side and on the buccal side and also the palatal side. I placed this sticky bone in the defect area, and when I was ready I covered my surgical area with a PRF membrane. Here you could see the closure, so I thought that it was tension free. And when the patient came to the suture removal, there was no flap dehiscence. But after 2 weeks of the surgery, the patient called me that she could see some blue things in the mouth. So that's why I know that there is a flap dehiscence and flap opening. The patient came to me and I could see that the dehiscence of the flap, it was in the first class. So it was less than 5 millimeters without any inflammatory signs. So I decided the conservative treatment. So I recommend antiseptic solution usage 3 times per day for the patient. And I chose the close follow-up, so I called back the patient in every 3rd day. We made a soft laser therapy and I checked the wound day by day that it is any inflammatory or not, and there wasn't. So I could wait until 2 months after the bone augmentation surgery, and then I removed the non-resorbable membrane. And when I removed the membrane, you could see that there is the formation of the new bone, so there is a callus formation. So right now we have to wait only for the mineralization of this area. So I decided to place a collagen membrane on the top of it and close it as I could, and we are waiting for the persecundum healing in this area and for the mineralization. In the last case, there is a quite young man who had some type of symptoms, no pain, but something he feels on the upper jaw in the right side, in the premolar and molar area. As you could see that there is no inflammatory sign in the mouth of the patient, so that's why we made a panoramic X-ray and after a CT scan. And in the CT scan, it is visible that the second premolar and the first molar, it is sitting in a quite big chronic inflammation. As you could see that when we are in the level of the first molar, that the buccal plate is totally missing. So if I remove this tooth without any alveolar socket preservation, at the end of the healing process, there will not be any bone in the vertical dimension and in the horizontal dimension as well, in the level of the 6. So that's why in that case it is very important to make a socket preservation, and because it is a chronic inflammation, so it is not in the acute phase, after when I remove the granulated tissues, I'm able to use some bone substitution material to preserve the width and the height of the alveolar socket. In this case, I decided to use the autogenous dentin graft. So first I removed both of the teeth. As you could see where my respiratory is, there was the big defect on the buccal plate. So we grind it. First I cleaned it, and after we grind it, the teeth, and you could see the material after the whole cleaning and producing process. So it did. From 2 tooth, we could reach a quite big amount of dentin graft material, and you could see that the consistency is such like the same that, for example, the consistency of the xenograft. I used also a collagen membrane fixed on the palatal side and on the buccal side with pins. I filled the alveolar socket with the mixage of the liquid PRF and of this dentin graft. I used the PRF membrane in 2 layers, so I put 1 layer on the top of the alveolar ridge. After I placed the collagen membrane and fixed it on the buccal side, and after I used another type of layer of PRF membrane to cover my area, and then I closed the wound. 1 week after, when the patient came for the suture removal, the wound healing was excellent, and now we are waiting for the healing of the heart tissues. As a take-home message or as a conclusion of my lecture, I would like to tell you that in order to minimize the rate of the complications, it is very important the appropriate choice of the surgical techniques and the materials. If it is possible, always choose some alveolar ridge preservation techniques, because if we have the opportunity to use the own tooth of the patient like a dentin graft and use it with the PRF, we could enhance the healing process very well. And also when we are able to preserve the alveolar socket, the dimension of the alveolar socket, it is an easiest surgery, like the vertical augmentation, for example, and it has less complications. If it is possible when you are making bone augmentation surgery, I recommend you to use some type of autologous materials, because it is enhance the procedure of the soft tissue and of the heart tissue healing. And with that, I would like to thank you for your attention, and I hope that it was a useful lecture for you, and goodbye.